Hello and good evening, and thanks for joining me this evening as we talk about new and emerging biologic agents in chronic rhinosinusitis with nasal polyps, pathophysiologic insights, and patient selection criteria. I want to let you know that this program is brought to you by Integrity Communicating Education. And this educational activity is supported by an educational grant from GlaxoSmithKline. I'm Dr. Michael Blaiss. I'm a clinical professor at the Medical College of Georgia at Augusta University in Augusta, Georgia. And I'm happy to be with you this evening for this CME presentation. Here are my disclosures for this particular lecture. And here are our learning objectives, the things that hopefully we'll be able to accomplish this evening. So we'll review the pathophysiologic and immunogenic molecular drivers of chronic rhinosinusitis that lead to the inflammatory endotypes and relevant comorbidities frequently observed in our patients that suffer with chronic rhinosinusitis with nasal polyps. We'll also discuss the differences between the currently approved and emerging biologic therapeutic options for chronic rhinosinusitis with nasal polyps using data from the phase 3 clinical trials and other analysis. And lastly, and very importantly, be able to incorporate an individualized patient-centric focus based on consensus criteria for our patients with chronic rhinosinusitis with nasal polyps when recommending a biologic therapy, or endoscopic sinus surgery, or other types of therapy that we'll also discuss this evening. So now we're going to start with our pre-test polling. Here's our first question. Nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? Is it interferon gamma, TNF alpha, interleukin 1 and 6, interleukins 4, 5, and 13, or interleukins 12, 17, and 33? Your answer, please. Okay. Next question. While typically predominant in 50% of patients with chronic rhinosinusitis without nasal polyps, which of these cells are thought to also play a role in patients with severe type 2 chronic rhinosinusitis with nasal polyps? Is it eosinophils, neutrophils, CD8 positive T cells, or Th1 cells? Your answers, and then hit that little submit button at the bottom. Okay, next question. A 39-year-old woman presents with nasal polyps and a history of moderate asthma. Her blood eosinophil level is 302 cells per microliter, and her total serum IgE is 25 international units per milliliter. Which biologic would be the most appropriate? Is it Memolizumab, Omalizumab, Rezalizumab, or Teslopilaman? So your answer, and then hit the submit button. Next question. A 49-year-old man with severe chronic rhinosinusitis with nasal polyps is placed on a biologic for his nasal polyps. When should he first be reassessed for response to treatment per the Euphoria guidelines and the multidisciplinary consensus algorithm? Is it any time in the first 6 months, at 6 months, between 6 and 9 months, or any time after 1 year? So your answer, and hit the submit button, please. Okay, and the next one. Right. So a 53-year-old man with severe chronic rhinosinusitis with nasal polyps presents for follow-up after 12 months on a biologic therapy. Prior to starting the biologic, he underwent endoscopic sinus surgery twice with nasal polyp recurrence within 6 months each time. He currently shows an adequate response to the biologic per the euphoria criteria and will not consider another surgery. What would be the most appropriate recommendation for this patient based on the euphoria guidelines? Is it switch to a different biologic, continue the biologic for another 3 months, consider fluticasone intranasal spray? The last answer, stop the biologic, go back to medical management. And again, after you answer, please hit your submit button. Okay, great. So that ends the pretest polling. And now we'll start with an overview of chronic rhinosinusitis and chronic rhinosinusitis with nasal polyps. So I probably don't need to tell anyone that's listening this evening is that chronic rhinosinusitis has a high prevalence in the United States. And for that matter, if you look at global epidemiologic studies, it is a common problem, in fact, throughout the world. It's estimated that over 11% of the US population, in fact, suffers with chronic rhinosinusitis. And as you can see here, a majority of those patients have the condition without nasal polyps. It tends to be higher in the female population than the male. The other 20%, in fact, have chronic rhinosinusitis with nasal polyps. And in fact, it's more of a predominant male condition. When we talk about the symptomatology that we see in patients with chronic rhinosinusitis, both with and without nasal polyps, there are 4 cardinal symptoms. One is nasal obstruction and congestion. Patients have nasal secretions and a lot of postnasal drip. Especially the patients that have polyps have a decrease or loss of sense of smell. And patients primarily without the polyps tend to have more facial pain and pressure. And if you look at the CT scan, you can again see obviously the big difference here in the control patient where the sinuses are all open and the patient with chronic rhinosinusitis nasal polyps there, in fact, having pansinusitis. And this condition has a major effect on the health-related quality of life of the patients suffering with it. Because of the severe nasal congestion, it's difficult to sleep at night. It's hard to breathe. They have trouble falling asleep, staying asleep, and this leads to a great deal of daytime fatigue. They have a lot of absenteeism and decreased productivity, and many of these patients have what we call presenteeism, that they'll go to work, but again, because of their fatigue, they're just not, in fact, as productive. Many of these patients complain of embarrassment with their problem. It causes a loss of confidence. And most of them that I see, and you probably see too, tend to be very frustrated with this condition. And you can see the endoscopy here in that patient that in fact is having a severe nasal polyps. So our diagnostic criteria, again, they have to have 2 of those 4 symptoms that we mentioned previously for 12 weeks or longer. And they have to have 1 of 2 objective criteria. One is endoscopy. One confirms the mucosal edema or polyps, or a CT scan of the sinuses that documents, again, the inflammation in the paranasal sinuses. So what is our standard of care therapy? What do we start in these patients that are suffering with chronic rhinosinusitis with nasal polyps? Well, the gold standard as far as starting treatment is intranasal corticosteroids. We usually use these at least twice a day, so higher dose than in patients with allergic rhinitis. We can use either the over-the-counter ones, or there are ones that are generic that are still by prescription. And generally, if patients are taught how to use these, they tend to be well tolerated. Usually, hand in hand, we also have the patients do nasal saline irrigation. This helps many of the patients. Studies have suggested that high volume irrigation seems to work the best. And some of the studies have suggested hypertonic works better than isotonic saline in these patients. And then many of us will do a nasal steroid irrigation. Now, there are no corticosteroid drops approved in the United States. So these types of things we're doing off-label, things like budesonide respules. And some of us may see better penetration than with the intranasal steroids. And then, unfortunately, not uncommonly, we have to do what's called a medical polypectomy. And that is the use of oral corticosteroids, because these are a very effective option for rapid relief of nasal blockage in those patients with polyps to improve their sense of smell. We all know about corticosteroids. We know that there are short-term risks associated with it, including thromboembolism and sepsis. And we're very familiar with all the long-term risks, especially things like osteoporosis and weight gain, cataracts, glaucoma, type 2 diabetes, and the list, in fact, can go on and on. And what we do know now, and mostly from asthma studies, is that you don't just get steroid side effects from daily or alternate day corticosteroids, but in fact, just cumulative burst of oral corticosteroids like we do for chronic rhinosinusitis with nasal polyps. You can get a cumulative effect and get at the same time long-term side effects. So we have to realize that burst also can cause side effects in our patients. So where do we go from there? In many cases, we may have the patient have endoscopic sinus surgery. Obviously, this provides, right after the surgery, instantaneous relief. But remember, surgery doesn't cure this condition. In fact, we don't have any medication or treatment that cures this condition at this time. So patients do have to start back on all their standard of care therapy, including the intranasal corticosteroids after surgery. Another option that's been approved by the FDA is the exhalational delivery system Fluticasone intranasal spray. So this particular spray uses fluticasone in a special device that you blow into, and then you have the nozzle that goes into the nose. When you blow into it, it causes the palate to raise up, increases pressure in the sinuses. So when you spray, ideally more of the fluticasone gets further down into the sinuses. And their phase 3 study showed that the polyps were eliminated in 25% in one nostril or both by week 27 versus placebo. So it's another option in the patient population. And in patients who have already had endoscopic sinus surgery, but now they are having problems again, another option for that patient would be steroid-eluting implantable stents. These can be placed in the ethmoid sinus in primarily the otolaryngologist office, and it uses mometasone as the steroid. It slowly releases over a 90-day period. And in their phase 3 studies, they showed a 61% reduction in the need for revision surgery. Now, so we talked about standard of care therapy, nasal irrigation, intranasal corticosteroids, short-term oral corticosteroids. So what percent of patients then does that fail? And what you see in the studies, failure rates anywhere from 30 to 50%. In some of the studies, it's higher, where in fact the patients need some other therapy and possibly, again, endoscopic sinus surgery. In studies that have been done over the years, and we've got a couple of these studies here in bullets here that have been done in the UK and in Europe, suggests that a nasal polyps recurrence after surgery is fairly high, anywhere from 20 to 35% at 6 months and 40% at 18 months. And then a long-term study done in Europe, looking over a 12-year period, showed that about a third of the patients over that 12-year period required repeat surgery, and 20% required multiple surgeries. So we have these patients out there that, in fact, continue to have revision surgery. continue to suffer severely with their nasal polyps. So let's talk some more about the pathophysiology of chronic rhinosinusitis with nasal polyps and discuss the role of inflammation and the immunologic drivers here leading to the severity of this condition. So we can talk about chronic rhinosinusitis with different inflammatory endotypes. So if we look at this chart here, type 2 disease, which again we're very familiar with asthma, allergic rhinitis, and other conditions. We know the effector cells, obviously the eosinophils, the mast cells, Th2 cells, type 2 innate lymphocytes. And it's driven by the type 2 cytokines, IL-4, 5, and 13. This is the major endotype that we see in both the Caucasian and African American population, leading to chronic rhinosinusitis with nasal polyps. Obviously, asthma, as we know, as I mentioned previously, many of these patients suffer with severe loss or decreased sense of smell. And again, you can have type 2 disease in patients without polyps, but that's a much lower percentage. And that leads us to the next group, which you see here, non-type 2. Sometimes you'll still see in the literature type 1. And you can see here the cells involved, the Th1 cell, the NK cell, the macrophage, and the cytokines here are interferon gamma and IL-12. This is the predominant type of inflammation that we see in patients with chronic rhinosinusitis without nasal polyps. And as we mentioned, this tends to be much higher in women than in men. And then the third group is another non-type 2, which if you saw in the old literature, type 3, which is predominantly Th17 cells and neutrophils. And it's driven by IL-17 and IL-22. It is a minority of the patients without nasal polyps, and it's the highest group with nasal polyps in the Asian community. So in the Asian community, it tends to be more of a type 3 condition. So let's look at type 2 disease because that's the predominant type that we see in the United States causing chronic rhinosinusitis with nasal polyps. So we had the epithelial barrier, which we know, in fact, we can see abnormalities, especially of the tight junction proteins that bind the epithelial cells together because they're not bound as well together. Bacteria, antigens, viruses, allergens, irritants, smoke, pollution, all can penetrate and activate the epithelium. That activation of the epithelium leads to the release of epithelial alarmins like TSLP, IL-33, and IL-25, which activate the type 2 innate lymphocytes, the Th2 cells, and again, help start or can contribute to the inflammation associated here in chronic rhinosinusitis with nasal polyps. We also can see bacteria colonization and biofilm production primarily from Staph aureus. We have the classic allergic pathway where we have the antigen being picked up and transmitted to the Th2 cells, which leads to upregulation of IL-4 and IL-13, which drive B cells to become plasma cells to produce IgE. In many of our patients with chronic rhinosinusitis with nasal polyps, this Ig is directed against the Staph aureus superantigen. This Ig then binds to mast cells and basophils, and on re-exposure to that allergen, we can see that mast cell literally explode, release hundreds of different mediators, histamine, leukotrienes, prostaglandins, and also we get release again of the type 2 cytokines. We have eosinophilic inflammation. We know that IL-5 is important in the bone marrow, leading to stem cells to become eosinophils, and is important for eosinophilic survival through the circulation. And then once it gets, in this case, to the sinuses, IL-4, IL-5, IL-13 lead to upregulation of adhesion molecules, which leads to chemotaxis of the eosinophils into the sinus tissue. And we're learning more and more about the role of IL-13 its effect on the epithelial cells, leading to changes in the epithelial cells, leading to increased collagen production, mucus production, goblet cell hyperplasia, and this increased fibrosis that we're seeing with IL-13, possibly also due to a reduction in tissue plasminogen activator. This leads to increased fibrosis and polyp formation. Now, what's been interesting is this paper that was published last year by Delamar that looked at the overlap between type 2 and non-type 2 inflammatory conditions. And I think this is an important concept because it's not static. It's not like you're either type 2 or you're not type 2, but there are definite overlaps. And one of the things that they talked about here, and I think very important, is about 26% of the patients, again, in the US with chronic rhinosinusitis nasal polyps have mixed inflammatory pattern. In other words, they don't have just the eosinophils, but in fact, they also have neutrophils. So I think we have to think about that it's not one or the other, but in many cases, especially severe disease, in fact, we may have both. And from their paper, I'm not going to go through this whole diagram with you, but I would suggest to get the reference and take a look at the paper. It talks about the mixed inflammation in severe type 2 chronic rhinosinusitis with nasal polyps, and talks about, again, the pathway leading to both eosinophilic and then neutrophilic recruitment in our patient population. So let's look at a couple of cases this evening. First one is Angela, and she was diagnosed with chronic rhinosinusitis nasal polyps 2 years ago. Now, she underwent endoscopic sinus surgery 12 months ago, but unfortunately, her nasal polyps returned. She had allergy skin tests that were negative. She was diagnosed with asthma at the age of 25. You'll notice she has an elevated total blood eosinophils of 600 cells per microliter, a normal total IgE of 25 international units per mil, and a baseline FEV1 of 70%, though we don't have from her history, is she on medication for her asthma at this time or not. So we know that, unfortunately, the standard of care medical management has not been helping her. She had surgery. Her polyps have already reoccurred. And again, we mentioned this previous, that again, just in the short term, we can see up to 40% have a redevelopment of polyps by 18 months. So she definitely has, especially with her having asthma, very likely this is a type 2 inflammatory condition. Now, we have Jason, who was diagnosed with nasal polyps 4 years ago. He had perennial allergic rhinitis since childhood to house dust mite and cat. His blood eosinophil level is 225 with a total IgE of 150. He doesn't have any history of asthma, or his FEV1 is borderline at 70%. So he complains that the intranasal corticosteroids are not working. He's noticed the polyps getting larger. It's affecting his quality of life. He doesn't like saline irrigation. It causes pressure in his ears. He's had 3 bursts of oral corticosteroids with antibiotics in the last 2 years. And again, we mentioned is that, there's a cumulative effect here. And he says he's willing to consider anything to get rid of the nasal polyps. And I wish I had a complete cure for him, but unfortunately I don't. So we have a lot of standard of care medical management limitations for him. The intranasal corticosteroids just aren't working well enough. They're not penetrating well enough to help his polyps. He doesn't like the saline irrigation, the ear pressure. Again, we mentioned about the steroid side effect. So we may have an inflammatory mixed type we talked about, or just type 2. It's hard to say exactly for sure, again, without biopsies. So with that, let's spend some time now talking about biologics and where they fit in the treatment of patients with chronic rhinosinusitis with nasal polyps. So These are the 3 FDA-approved biologics for the condition. I'm going in the order at which that they were approved by the FDA. So first approved in June of 2019 was Dupilumab. We know it blocks the IL-4R alpha receptor, therefore it blocks the activity of IL-4 and IL-13. Its indication is add-on maintenance for adults, so this is 18 years of age and older, with uncontrolled chronic rhinosinusitis with nasal polyps. You can see the dosing here, subcutaneous every 2 weeks. Phase 3 studies, and we'll go over Sinus 24 and Sinus 52 in just a minute. Next is Omalizumab, which we know blocks IgE. Its indication by the FDA is add-on maintenance for adults with inadequate response to intranasal corticosteroids for nasal polyps. Its dosing is the same as the dosing that we use for asthma, which is based on body weight and serum IgE levels. And that's why you see the dosing here from 75 to 600 milligrams every 2 to 4 weeks subcutaneous. And we'll go over their phase 3 trial in just a second. And the last one approved is Memolizumab. That was last July. We know it blocks IL-5. It has the same indication as Omalizumab, add-on maintenance for adults with inadequate response to intranasal corticosteroids for nasal polyps. It's given subcutaneous every 4 weeks, and we'll go over the SYNAPSE study, its phase 3 study, in just a minute. So let's take them in order. First, we'll look at Dupilumab. Now, all of these studies, there were 2 primary endpoints, or co-primary endpoints. One is the nasal polyp score. And nasal polyps are scored from 0, no polyps, to 4 polyps coming out of the nostril, below the inferior turbinate. So the highest score, since we have 2 sides, would in fact be an 8. And in fact, in all of these studies, patients had to have a score of at least 5 to enroll in the study. The second co-primary endpoint is nasal congestion or obstruction. In 2 of these studies, it's scored from 0 to 3, 0 being none, 3 being severe and can't live with it. The last study we'll talk about did a 0 to 10. So those are the primary endpoints that the FDA requires. And then all of these also had a great deal of secondary endpoints like SNOT-22 for quality of life and a smell test and others. So let's look at primary endpoint here for Dupilumab. First, the nasal polyp score. Sinus 24 was a 24-week study on Dupilumab versus placebo. Sinus 52 was a study with patients on Dupilumab every 2 weeks for 24 weeks, and then half of that group went to every 4 weeks for a total of 52 weeks. So you had one group there's every 2 weeks for 52 weeks and one every 4 weeks. And if we look at the results for nasal polyp score, if we look at improvement of 2 points or greater out of that 8-point scale, it was almost 50% of the Dupilumab group in both studies versus 1 or 5% in the placebo group. And if we look at nasal congestion or obstruction, again, remember it's a 0 to 3 scale. You'll notice here in both studies, Sinus 24, Sinus 52, in fact, there was a significant improvement in nasal congestion with Dupilumab compared to placebo. Very importantly, they looked at the need for oral corticosteroid burst and or surgery in the patient population. And this is the percentage of patients in a pooled analysis of Sinus 24 and 52. And you'll notice here that about 41.8% of the patients on placebo required either surgery or steroids, where only 12.5% of the group that was on Dupilumab. What about side effects? Again, we've been using these biologics, including Dupilumab, for other conditions. So I think all of us have a pretty good understanding of the safety record of these biologics. In the polyp studies here, you'll notice the most common side effect, and it was no different in placebo, was nasal pharyngitis and headaches. You'll notice nasal polyps got a lot worse in the placebo group than in the dupilumab group. Okay, now let's move on and talk about omalizumab. And you'll notice here, this again is the nasal polyp score. Remember, we talked about that 0 to 8 score. And what we see here again with omalizumab, these are two 24-week studies. They did not do a 52-week. This is two 24-week studies. But in both of these studies, there was significant improvement, as you can see here, associated with nasal polyp score. They also looked at nasal congestion, and again, a 0 to 3 scale. And you'll notice again that the patients that received omalizumab had a significant improvement in their nasal congestion score that was seen in the placebo group. What about safety in these two 24-week studies? Well, we've had omalizumab now for over 17 years, and we know it has a very good safety record. Not surprising, the most common side effect, which was in placebo, was asthma exacerbation. But you'll also notice, again, the things we normally see: nasal pharyngitis, headache, backache. Now we'll move on to the third drug that was approved, and this is Memolizumab. And we're looking at the data a little differently. This, in fact, was a 52-week study. And what we're looking at here is, you'll notice over on the left for the nasal polyp score, you'll see no change, 1 point, 2 point, 3 point, 4 point, 5 point improvement. The bottom line is, when you look at this data, as we've looked at the other biologics, there was a significant decrease in nasal polyp score with Memolizumab at the end of 52 weeks compared to the placebo. And if we look over on the right, we're looking at nasal congestion score. And again, this was a 10-point scale. So you'll notice here 1 to 3 point improvement, 3 to 5, greater than 5. And again, there was a significant improvement. So this agent also met both primary endpoints and for approval for this biologic in the treatment of chronic rhinosinusitis with nasal polyps. Very importantly, they looked at the need for surgery over the 52-week period. And what you'll notice here in the placebo group, that it was a little over 20% ended up having to have surgery. It was about 9% in the Memolizumab group, and you can see here that was a significant difference. So again, preventing the need for surgery in these patients by being placed on Memolizumab. And if we look at its safety profile, again, has a very high safety profile that we've seen in our asthma population, including the most common adverse events, and really no different than placebo: nasal pharyngitis, headache, sinusitis was higher, and nasal polyps was higher, again, in the placebo group. Again, not surprising. Now, what about emerging therapies? So we have benzorilamab, which blocks IL-5 by blocking the IL-5R alpha receptor on eosinophils. The Ostro study has been published for severe nasal polyps. It did meet the co-primary endpoints, though it did not meet several of the secondary endpoints. It was just one study, so the FDA decided not to improve the agent on the one study alone. They've got, obviously, as you can see here, a second study that's called the Orchid study, and it should be finished in July of 2024. And at that time, we'll see if benzorilamab gets approved. And there's a study ongoing right now with Teslopilaman in patients with severe chronic rhinosinusitis nasal polyps. It is also to be finished in 2024. So there's a good possibility, we'll have to wait for the results, obviously, in a couple of years, we may have 2 more biologics approved for this condition. Very importantly, when you go back and you look at all the secondary endpoints that were done with these biologics, they really showed great improvement in the 3 approved. Both Dupilumab, Omalizumab, and Memolizumab showed significant improvement in the 22-item sinonasal outcome test, which is a measure of symptomatology and quality of life, a validated instrument. So not only do we see improvement in polyp score and congestion with all 3 of these agents, but we also see basically improvement in symptoms and quality of life. Okay, so how do we go about treatment selection? Because I think that's probably the #1 question I get, where do we go from here? So there are a lot of separate algorithms that have been developed. Here is one that was published last year by Joe Hahn et al. Called the Multidisciplinary Management Algorithm of Chronic Rhinosinusitis and Nasal Polyps. So they talk about a majority of patients, minority of patients. So they say for a majority of patients, you start with sinus surgery if, in fact, they do not get better with standard of care therapy. I have some disagreement with that. I think that that all patients should, with shared decision-making, as I'll talk about in a few minutes, be given at least the option of surgery versus some of the other treatments, including biologics. But to follow this algorithm, so we have the sinus surgery, then they go back on their intranasal steroids, and they go back on their irrigation. But what if the problem redevelops? Then they talk about biologics, especially if they have comorbidities, or repeat surgery, or if they have asthma, exacerbated respiratory disease, desensitization, or a steroid sinus implant, as we mentioned, or maybe just a medical polypectomy again, and then go from there. And then they talk about the minority of patients that there's a contraindication to surgery, or they have severe asthma, steroid dependent. Then those patients may, in fact, definitely not be candidates for surgery, or would go possibly straight to a biologic. Now, how do we define uncontrolled and severe chronic rhinosinusitis with nasal polyps? So uncontrolled disease, which this comes from the Euphoria guidelines, which are the European Forum for Research and Education in Allergic and Allergy and Airway Diseases. Uncontrolled, and I think both our patients fall into this category, persistent or recurring chronic rhinosinusitis nasal polyps despite long-term intranasal steroids and having 1 or more courses of oral steroids in the preceding 2 years and or previous sinus surgery. So definitely both of our patients. Severe, these patients have bilateral disease with nasal polyp score of 4 or greater. Now, we haven't done endoscopy on these patients, but my guess is, from just the history and what we're told, my guess is their polyp score is definitely above 4. And so they probably also fit under this category of severe, having persistent symptoms despite long-term intranasal corticosteroid need for added therapy. Now, one of the things I think that's extremely important is shared decision-making, because there is no one treatment that fits all for patients with chronic rhinosinusitis with nasal polyps. And we need to know the patient's preferences and values in determining what may in fact work best for them and lead to the greatest adherence. So the American College of Allergy, Asthma, and Immunology, along with the American Rhinologic Society, developed a patient decision aid for shared decision-making for our patients with chronic rhinosinusitis with nasal polyps. There's a version for patients seeking first-time care for their polyps, and a version for patients who have already had surgery and are coming back because they're still having symptomatology. It goes through the different treatments, it goes through the pros, the cons, the outcomes, the cost, and then you see here your turn. And these are questions that the patient is asked to get their values or preferences. And by using a tool like this, one can get a handle in communication with the patient what would be the next best step as far as management of their condition. So let's look at the euphoria guidelines for selecting a biologic. And the statement in blue is key. Predicting response in any individual patient's not yet possible. There is no way I can or anyone else can tell you at this time which biologic is definitely going to work better in which patient. It is truly trial and error, and I tell patients that from the beginning. We're going to try this for 6 months, and then we'll decide where we go from there. And I follow, as you'll see in a second, the euphoria guidelines. So who should go on a biologic? You've confirmed the diagnosis of uncontrolled severe chronic rhinosinusitis and nasal polyps, especially if they have comorbidities like asthma, allergies, that you determine then the type 2 inflammation is likely. You inform the patient. This goes back to shared decision-making on treatment options, their perspectives, their risk, and then you make a decision. Should it be surgery? Should it be a biologic? Should it be one of these other treatments that we talked about? And then if a decision is made for a biologic, then you go from there. And then if they also have asthma, you really should collaborate with an asthma specialist as far as selecting, again, the best biologic for that patient. So let's come back to Angela. She's 41 years old. What additional tests would you ask for? I really want to know how well her asthma is under control. And that may really make a decision as far as where I would go as far as possible treatment of this patient, especially with a biologic. Would you recommend revision surgery for this patient? Again, it depends upon her asthma. If asthma is not a major component, she's not having a lot of problems with it, then possibly. But if she does have asthma, as we know, and it's not under good control, and she has polyps, then maybe we can use one product to treat both conditions, in which case would be a biologic. As far as which biologic, the only one she really doesn't qualify because of the dosing is Omalizumab, because her IG level is only 25, and you need to have a level of at least 30. So really, Dupilumab, Memolizumab, a lot of that I make a decision on as far as what's covered by their insurance. What information would you give her to facilitate shared decision making? Well, you tell her the pros of each of these. Dupilumab's every 2 weeks, Memolizumab's every 4 weeks as far as injection. That may be very important to her. It may not be. So again, going through the differences in the different treatments. And what about Jason? What tests would you ask for? Again, his FEV1 is 70%, so I want to know about asthma on him also. And would you recommend endoscopic sinus surgery? He's never had it, so that's definitely an option. But I find out once having shared decision-making with Jason, nope, no surgery on me. So that kind of leaves us then with biologics. And again, I think any of the 3 biologics would be appropriate for him. We can explain the differences in them. And obviously, cost would also probably play an issue here too. So let's say we put both these patients on a biologic. So if we follow the euphoria guidelines, we reassess them after 6 months. And what we're looking for is at least in 6 months some improvement, like some improvement in sense of smell or nasal polyp score or nasal congestion or SNOT 22. And if the answer is no, then we either do surgery or we switch to a different biologic. If the answer is yes, and the improvement is acceptable to the patient, well, then we continue that biologic therapy. If the answer is yes, but the patient still says, I'm a little better, but not the way I want to be, you may want to do surgery under biologic protection, or maybe just a burst of oral steroids and give the biologic another 6 months. Now, we reassess again at 12 months. And by 12 months, we really should see excellent relief of the patient if the biologic is doing what we want it to do. So improvement in nasal polyp score and nasal congestion, no need for surgery or steroid burst. If the answer to that is no, try another biologic, surgery. The answer is yes, because again, the biologic doesn't cure the condition. We continue their therapy. So how do we differentiate from the biologics? And there are no head-to-head studies. And I already mentioned to you, all three of these agents work. The problem is I can't tell you which is going to work best in which particular patient. So as we've seen with asthma, many times we have to switch biologics. We may have to do the same thing in chronic rhinosinusitis with nasal polyps. So in summary this evening, understanding the pathogenesis of chronic rhinosinusitis has continued to increase in recent years, and more new data is coming out. It's a fascinating condition to understand the pathogenesis. And biologics have definitely improved our understanding of the pathophysiology, and extremely important, the management of these patients, especially when they have other type 2 comorbidities. So the treatment of chronic rhinosinusitis nasal polyps should be based on the molecular drivers of inflammation. We measure the response to treatment. We share decision-making, the patient's preference. And with the new and emerging options out there, hopefully the patients that have recalcitrant conditions will really diminish and have a much better quality of life. So with that, I'm going to move on now, and we're going to go to our post-test polling. And we're coming back to our first question here. Nasal polyps, here we go, generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? Interferon gamma and TNF alpha, IL-1, IL-6, IL-4, 5, and 13, or IL-12, 17, and 33. So your answers, please. Great. So everyone got it correct now on the post-test. It is IL-4, IL-5, and IL-13. Next. Next question. I'm sorry, I'm not seeing the next question. Here we are. While typically predominant in 50% of patients with chronic rhinosinusitis without nasal polyps, which of these cells are thought to also play a role in patients with severe type 2 chronic rhinosinusitis with nasal polyps? Is it eosinophils, neutrophils, CD8 positive T cells, or Th1 cells? Your answer, please. And then hit the submit button. Well, in fact, the answer here, in fact, is neutrophils. In these patients with severe type 2 disease, not only are we seeing eosinophils, but we're also seeing neutrophils. Next question. A 39-year-old woman presents with nasal polyps and a history of moderate asthma. Her blood eosinophil is 302 cells per microliter, and her serum Ig is 25 international units. Which biologic would be the most appropriate? Is it Memolizumab, Omalizumab, Rezalizumab, or Teslopilaman? And in fact, the answer is, in fact, Memolizumab. The reason that Omalizumab is not the correct answer is really the FDA guidelines on dosing, that the level needs to be at least 30 international units per milliliter. Rezalizumab and Teslopilaman do not have an indication by the FDA at this time for nasal polyps. So the answer is Memolizumab. Next question. A 49-year-old man with severe chronic rhinosinusitis nasal polyps is placed on a biologic for his nasal polyps. When should he first be reassessed for response to treatment per the Euphoria guidelines and the multidisciplinary consensus algorithm? Is it any time in the first 6 months, at 6 months, between 6 and 9 months, and any time after 1 year? And looks like everyone got the answer correct this time. This is great. And the answer is at 6 months. And then our last question. A 53-year-old man with severe chronic rhinosinusitis with nasal polyps presents for follow-up after 12 months on a biologic therapy. Prior to starting the biologic, he underwent endoscopic sinus surgery twice with nasal polyps reoccurrence within 6 months each time. Currently shows an adequate response to the biologic per the Euphoria criteria or not consider another surgery. What would be the most appropriate recommendation for this patient based on the Euphoria guidelines? Is it switch to a different biologic, continue the biologic for another 3 months, consider Fluticasone intranasal steroid spray, or stop the biologic, go back to medical management? And it looks like everyone's got the correct answer this time. Great. And that is, according to Euphoria guidelines, you would switch to a different biologic. So with that, we'll move on to our question and answer session. So if you have any questions, to type them in, and I'll do my best to try to answer them for you this evening. Any questions? Okay. Are any of these medications in generic form yet? Well, obviously, the intranasal corticosteroids, which, for standard of care therapy, are over the counter, almost all of them. In fact, mometasone will be over the counter shortly. So all of those are. But everything else, as of right now, obviously all the biologics are still fairly new, though we may see a biosimilar in the near future for Omalizumab. So we'll have to wait and see if that happens. So as far as the biologics, yeah, at this point in time, there are no generics. How big a role should concentrations of IgE and eosinophils play in choosing a biologic? Well, it's kind of interesting. I think that's a fascinating question because, we do have that for other type 2 disease like asthma, but we don't have that for nasal polyps. And I think the main reason we don't have that for nasal polyps is that virtually all the patients with chronic rhinosinusitis with nasal polyps, in fact, have type 2 disease. So they tend to have increased levels of, in fact, eosinophils. As far as IgE in and of itself, the level really making a difference, I don't think so from the data. We can even debate, it related to Omalizumab and asthma, where there's studies that show that if you're outside the FDA guidelines, the agent still works. So I think all three of these agents work in patients that have this condition. The problem is we don't have specific biomarkers that clearly tell us which agent works best for which particular patient. We're not to the level that we have for cancer treatment where we have genetic biomarkers. And until we do, we're still going to be in this trial and error situation. When starting immunotherapy, do you always have patients come to the office for the first administration? How soon do you release them to administer at home? Okay, well, so immunotherapy is approved, allergen immunotherapy is approved in the United States by both the subcutaneous method and by the sublingual method by the tablets. If it is by subcutaneous, because of the risk of anaphylaxis, all injections should be given at a healthcare facility where anaphylaxis can be treated. So I never let patients have subcutaneous immunotherapy given at home. Oh, okay. I'm glad you clarified that. So we'll go back. Sorry, I was referring to the medicines discussed in this lecture. Great. Okay. So the biologics, as far as is releasing them, I always have the, so if we're talking about Dupilumab and Memolizumab, I always give, in all three of them, I always give the first dose in the office. For Memolizumab and Dupilumab, because of the label, they can then take it at home the rest of the time. They can, give themselves the injection every 2 or 4 weeks, depending upon what treatment they end up going on. Omalizumab has had this warning about anaphylaxis, which, to be perfectly honest, is extremely rare. And so many of us will allow patients after the first dose of omalizumab is given in the office, or the first 3 doses, to take omalizumab at home. I think that requires a discussion with the patient, and again, that they understand that there is that particular warning on the product. But in general, I think all of these agents are safe for home administration, especially after 1 or 2 or 3 doses in the clinician's office, to make sure that they're able to use them correctly. I hope that answers the question. You're welcome. So we'll wrap up this evening, and thank you, and thank you for those questions. Those were great and extremely pertinent. So I appreciate that. So if you want additional resources and information related to the subject, please visit the website integrityce.com/npresources. You'll now be directed to the evaluation, or to claim your CME credit after this, you can go to integrityce.com/chronic rhinosinusitis nasal polyps, CRSWNP, eval/8. So you have a great evening, and thank you for joining me in this CME presentation.